Prior to the COVID-19 pandemic, Louisa provided part-time childcare and picked up her grandson from school every day, which she always looked forward to. Both of these things were taken away from her at the onset of the pandemic. Louisa has a few health issues that put her at an increased risk of an infection, making it crucial that she observe physical distancing, even though she really enjoyed the company from her grandson. Now Louisa goes out to the grocery store once per week and tries to get outdoors every day, but like many others, she's finding it harder to motivate herself to get outside. Louisa's expressed that she's been feeling more sad and lonely and isn't sure what she can do to change this. The coronavirus pandemic has changed life as we know it. There's still uncertainty around what the future looks like, and for many, this can lead to stress, depressed mood, and feelings of loneliness. These feelings may be intensified for older adults who may be at higher risk for infection, especially those with severe underlying medical conditions like heart or lung disease. Strategies that include self-care and technologies to help stay connected have some evidence to support their effectiveness in improving mental health and well-being. However, while these approaches have been shown to help loneliness and isolation for some during the pandemic, it's not a one-size-fits-all solution, as factors like age and income have had disproportionate effects on people. We've asked Dr. Parminder Raina to talk about the evidence surrounding the impact the COVID-19 pandemic has had on older adults' mental health. Dr. Raina is a professor in the Department of Health Research Methods, Evidence and Impact, lead principal investigator of the Canadian Longitudinal Study on Aging, and scientific director of the McMaster Institute for Research on Aging. Dr. Raina specializes in the epidemiology of aging, with emphasis on developing the interdisciplinary field of geroscience to understand the processes of aging from cell to society. Thank you very much for joining us this morning, Parminder. What do we know about the impact of the pandemic on the mental health of older adults?
Thanks for asking that question, Anthony. One of the things that as the data are emerging, we are seeing that overall at the population level, that the depressive symptoms, specifically I'm going to talk about depressive symptoms in older people, have increased during the pandemic. And this is not only what our data shows, this is the pattern we are seeing in most developed nations. Because of the lockdown, because of the public health measures that were put in, that it is impacting the mental health of old people. For example, in Canada, what we saw, especially when you have data on depressive symptoms, on mental health prior to pandemic, and then you measure that again during the pandemic, what we are seeing that the overall at the population level for people over the age of 55, it went from 16% of the population to almost 22% of the population. So there was a substantive increase. Other interesting thing that we have observed and other studies have observed that if we follow people over 12 months during the pandemic, we thought that there would be initial shock of pandemic that got people worried. In fact, the depression stays high throughout the 8 to 9 months of follow-up we did on these individuals to almost 22%. So it doesn't go back. It's sustained effect that is on people.
But I believe some of the evidence shows differences, right, between the 55 to 64-year-old adults and the elderly or oldest old. Is that right?
That's correct. In our data, we have shown that the major impact of pandemic on mental health of depressive symptoms is in 55 to 64-year-old individuals, higher in men as well. And it's not that there is not a depressive symptoms increase in the oldest old, but it is not as profound as it is in the younger population. Other things that we have seen is that it affects people disproportionately depending on what socioeconomic strata they might be.
What are some of the key social factors that might also be having an important influence or impact on this?
This is a group of individuals who are still in workforce. So there might be changes in their work. Financial stressors might be more, and majority of people in this age groups are also caregivers for other older people. So those factors might be the factors that are actually putting stressors on people. And when we look at health stressors during the pandemic, such as caregiving, such as limited access to care, or a death or a sickness in family, those all become important in relation to the severity of the depression symptoms. And that also is higher in younger, older adults than the older adults.
And I think one of the things that the evidence has said is that different segments of the population have been very differentially affected by the pandemic. I'm wondering if you can speak a little bit about some of the key social factors and social determinants of health that have emerged from the data.
So it is true that we are all in the same storm, but we might be in different boats tackling this storm. And what we are seeing from our data, and we have seen from other studies as well, and it's important to keep this in mind, that people in low income groups, where their household income is less than $20,000 a year, for example, had higher depressive symptoms prior to pandemic, and they stayed very high. So they had no more room to get worse in that sense. So they were actually experiencing the brunt of this depressive symptoms. That the impact of pandemic was disproportionately on those individuals who came from low socioeconomic groups, and they carried that depressive phenomena that they were already experiencing forward during the pandemic as well.
In some of your work, the evidence has highlighted two key elements in particular that seem to have had a major impact on mental health. And one is loneliness, and the other is family conflict. Can you say a little bit more about those two factors?
Right. So when we looked at the data from our Canadian Longitudinal Study in Aging, which is a Canada-wide study of 28,000 people that we studied during pandemic. So it's a big sample. So the evidence is robust from that point of view. What we found was that loneliness was associated with depressive symptoms. And we wanted to see, is it impacting people equally across different types of depressive symptoms? When we started to parse data by severity of symptoms, what we found that the people who were lonely or reported higher proportion of loneliness had 15 times increased risk of experiencing depressive symptoms, serious depressive symptoms, in comparison to people who showed depressive symptoms, but they were on a very low level trajectory, so mild depressive symptoms. And the same thing we observed with family conflict, where the severity of the symptom was substantive. One of the factors we saw is the violence of the family conflict. Whether they were living together, we don't know that. This was the general experience of the family conflict, and within that, perhaps family violence, that they were almost 8 times more to experience serious, severe symptoms during the pandemic. And this was a data that we looked over time. Other factor, social factor that emerged, not as strong as these two, was the burden of caregiving. We also saw that the people who were providing care to their family members also experienced much more higher proportion of severe symptoms than people who had few symptoms of depression.
And when you say providing care, caring for an older parent in the home, for example, or caring for children dependents in the home, or both?
Both. We didn't parse that out. It was a question that we asked whether they were providing caregiving, and did that add stressors into their day-to-day life. during the pandemic, and that was the response. And I think the key message here is that there were some very unique stressors that were created during the pandemic, such as challenges of caregiving, such as lockdowns and being lonely, such as conflict because you are sort of confined to certain spaces, and also access to services. A lot of people were not getting access to services, and all those things together actually had much more severe impact on the severity of the symptoms. But from those multiple health stressors or stressors during pandemic, two that really stand out are loneliness and family conflict.
I think one of the things that has been really challenging during the pandemic is everything has happened fast in terms of scientific, knowledge and understanding. How have you responded? What are some of the methods that you've used to try to improve the quality of the science around, understanding the impacts of the pandemic?
I think this is a challenge that everybody has faced during pandemic. How do you generate robust evidence that tells you that some of the things we are observing is a function of the pandemic? And I think Canada, from the point of view of an aging population, was in a good place because we had this research platform called Canadian Longitudinal Study that started in 2011. We have been collecting much of these data prior to pandemic. And in March 2020, when we started to observe that this was going to be a serious event in most people's lives, we actually quickly pivoted to start collecting data related to mental health, consequences of infection and how the long COVID works. So we actually had the perfect platform available in Canada to collect these data and compare what was happening prior to that. And I think that has been one of the lessons, that it's important to have research platforms in countries so you can actually respond to these major crises that emerge. And similarly, in other countries that had similar cohorts have pivoted to collecting data that is providing much more robust evidence in comparison to sporadic surveys that were happening during the pandemic, where we didn't know what was the history of the people prior to that. And I think it also becomes important that the people you reach out to, I don't think we could do any of this work if people were not providing these data for us to answer these types of questions. And I think that has been one of the reasons we were able to generate evidence. And second is that when you design these studies, you actually use standardized tools to collect data, that you have confidence in data that you are generating. For example, in our study of looking at depressive symptoms, we used a well-established depressive symptoms, which had been validated for many years. So having that type of tool where you have a confidence is important to interpret the data.
And I think from what you're saying, access to a representative sample, because those things like income and other demographic factors, whether somebody's living alone, whether they're a caregiver, they seem to have a major impact on these outcomes.
To make sure that the quality of the sample you have represents and is generalizable to the population that you are studying. And I think that's where population cohorts like CLSA become important, because they have ability to assess whether the data we are generating is generalizable to the population or not.
And I think we're fortunate too. We've had colleagues who are also looking at high quality data sources coming in and conducting, reviews and syntheses on the best available data at the time too.
Right. And I think that's an important point to raise. When we are looking at our data, of course, these results are coming from our study, but we are also contextualizing to see what's happening in other parts of the world who are collecting similar type of data. Are we seeing consistent patterns? And so far, the good news is the patterns are very much similar, especially the data coming from the developed world.
Yeah.
Because the challenges were the same.
So this is really important evidence and data. Is based on the evidence. Is there anything emerging as a particular intervention that clinicians or as a country that we should be doing to help with the mental health of our adults during the pandemic?
Uh, I think that what this data highlights is that we already know many of the interventions that work in relation to promoting well-being in individuals. What it highlights is that one solution is not going to fit all the people. We need to tailor our interventions depending on the population that emerges as experiencing mental health symptoms. So people who are lonely, they are a very different socio-demographic group versus people who are in the low-income group. And I think when we are thinking about interventions from a policy point of view, from a clinical point of view, we have to think about who is the recipient of that information, what is their context, what are their social determinants of health, and then tailor interventions to from that point of view. And I think that's what we are seeing from this data. It's one size is not going to fit everyone. It's going to be much more nuanced implementation of the policy or the clinical decision making in relation to the interventions of mental health during pandemic.